Jocelyn Medal. I am presenting today, starting from scratch, a chronic cutaneous infection of Mycobacterium chelonae. Now, firstly, you might be wondering, what is Mycobacterium chelonae? Well, it is a rare cause of infectious disease that is classified as a rapidly growing non-tuberculosis mycobacterium, which is ubiquitous in nature. It is primarily caused by disseminated cutaneous disease in immunocompromised individuals, such as those on long-term monoclonal antibodies, corticosteroids, and immunosuppressants. Typically, people who are infected develop nodules that can disseminate and drain spontaneously. Diagnosis is made through culturing of drainage and performing biopsy, as can be seen here in these two pictures. It is important to conduct acid-fast bacilli testing, especially if the patient has pulmonary disease, to rule out other possibilities. PCR is the only method that can be used to distinguish between subspecies, which is very important because they're sensitive to different medications. In terms of treatment modalities, Mycobacterium chelonae is very hard to treat. There's currently no clinical trials that have determined the best treatment modalities. However, the clinical standards are that patients receive oral therapy for 4 months. 2 oral agents are from the list of trimethoprim sulfamethoxazole, doxycycline, levofloxacin, clarithromycin, or azithromycin. For more disseminated diseases, as the one that the patient exhibited, they need up to 2 medications, which are IV agents, and a third one as well. The IV medications are typically tobramycin or levofloxacin, and a selection of either cefoxitin or imipenem. The regimen is used for several weeks or until there has been some clinical improvement. Afterwards, a patient is transitioned to oral medications, which can last from 6 to 12 months. So as you can see, very prolonged case. For this case, a 52-year-old female presented with a history of steroid-dependent COPD, asthma, chronic anemia, uncontrolled hypertension, cellulitis, and severe osteoporosis. She presented with extreme swelling and redness of her right arm, and her husband stated that the swelling had started very suddenly and was increasing rapidly. Her blood pressure was 165/81, pulse was 98, oxygenation was 97%, and white blood count was 8.7. Physical exam demonstrated an erythematous upper right arm that was warm to touch with 1+ edema. In terms of presentation, there was a lot of confusion going on as to differential diagnoses. She could be having a DVT or cellulitis, which she had had previously, so an ultrasound was conducted, which showed no abnormalities. There were cultures that were performed, and she was given IV vancomycin and Zosyn with referrals to dermatology and rheumatology. 1 month later, the patient's nodules were drained, and a sample was conducted, which was sent to the state lab, which demonstrated Mycoplasma chelonae. In order for her treatment phase, she was at first started with IV tobramycin, oral clarithromycin, and levofloxacin, which we thought would be for a total of 4 months. However, this drastically changed because she had a decrease in glomerular filtration rate because of the tobramycin and was tried on tigecycline. However, she also had increased abnormal LFT values with that. So her regimen was therefore changed to levofloxacin and oral clarithromycin, as well as doxycycline. The brief period that she was on tobramycin showed a grand relief of the subcutaneous nodules and control. However, recently, about 10 months after original presentation, she presented with an infectious abscess of the right elbow, and excision was performed, which demonstrated preliminary results of few acid-fast bacilli. As you can see, Mycoplasma bacterium is incredibly difficult to treat. It requires diligent collaboration between the patient, general surgeons, internists, infectious disease specialists, nursing staff, and wound care specialists to determine the best treatment options. It is necessary to recheck labs and also to perform culture in order to determine the best medications that can be used. Also, you have to learn to see whether there are any toxicities that have been caused in the patient. It's typically not a disease that has been seen in clinical settings so much. However, its presentation is very much confounded with other factors. Therefore, it's really important to perform PCR, especially when you have an immunocompromised patient, because this could greatly aid the recovery time. There's still a lot of research that needs to be done in terms of Mycobacterium chelonae in order to determine the best treatment modalities. And currently, there has been some case reports showing bacteriophages to help with the treatment. And thank you so much for your time. And also, if anyone had any questions as well.
Yes, thank you so much, Jocelyn. We do actually have one question for you, and it's just simply, how does one acquire this bacterium?
Sure. So typically, the patients that acquire it are immunocompromised individuals. In our case, our patient was immunocompromised because she had had a long history of steroid-dependent COPD. Typically, it's something that people have on their skin as well and just in the environment. So any sort of puncture wounds can cause the bacterium to infect the skin, and from there it rapidly disseminates.